So good evening, everybody. I'm absolutely delighted to welcome this evening Dr. Kristýna Frühaufová from GYNEM IVF in Prague. I am Barbara Scott, Chair of the Association of Reproductive Reflexologists, and I'm chairing this evening's session on behalf of my IVF Answers and the European Fertility Society, which, as many of you already know, provide a wide range of webinars for patients that provide actually a vast array of information that help you as patients to make decisions about your treatment, but also give you the opportunity of listening into these specialist webinars that allow you also to ask questions that are individualized to your own circumstances. So I'm thrilled to have Dr. Kristýna with us this evening, speaking for us about IVF for women over the age of 35, looking at the latest techniques and the latest approaches. Now, I am just going to say she's very kindly with us this evening, that has a bit of a croaky throat, so we're going to be really kind to her and try not to make her have to talk too much. The final thing to say before I hand over and we start sharing the presentation is just to say, please do post your questions if you have them. They are anonymized, so it's safe for you to post them. I do sometimes use your first name just to identify that we've got the right question for the right person, and we might have some additional questions to ask you. So please do look forward to the session, and a huge thank you for Dr. Kristýna for being with us this evening.
Thank you. I'll try not to lose my voice throughout the session. So if I do, just please be patient with me. So first of all, I'm going to start with a very brief presentation. My topic is quite wide, and there are lots of aspects of how to optimize the success of IVF in women over 35 years of age. I'm going to look into some latest technology to see the feasibility of those, and also to look into, let's say, briefly into some pre-treatment methods that might be suggested for women, especially with lower ovarian reserve. So let me start with a brief introduction. So why do we categorize women according to their age? The reason being is that we know that the female fertility naturally declines after the age of 35. It's not that once you turn 35, there's no chance to get pregnant. However, the egg quality does deteriorate after this age limit. So we know that it's the egg quality that eventually affects the quality of the embryo. So if you have abnormal embryo, then of course the chances for pregnancy are lower. The goal of the modern IVF is not to mend the genetic issues of the embryo, because that's something that we cannot do both ethically and technically at this moment, but try to pinpoint the right stimulation and the right approach to that specific patients to guarantee the best possible outcome. If we look, I'm sorry, it doesn't. Okay. This graph, I don't know if you can see it clearly, basically shows the correlation in between the age and the euploidity of the embryos, which basically means how is it likely for the woman to have a normal, genetically fine embryo that most likely will lead to pregnancy related to her age. We see that there's a rise in the ages of, 18 to 90. The lowest, just give me a couple of seconds.
Please don't worry. Take your time. Take your time.
Yeah. Thank you. Actually, the lowest risk of having abnormal embryo is around the age of, let's say, 22 to 28 or 30. Then it gradually goes up. And once the woman reaches around 40 years of age, most of the embryos that we gain will be abnormal. We can see that towards the age of 44, 45, let's say more than 90% of the embryos will have some genetic abnormalities. So that is why the age is so important to us. So what we want to see, what we want to test before starting the IVF cycle itself. So we want to measure something that's called the functional ovarian reserve based on the AMH, and also something that's called the follicle count, which means that we will count the small follicles on the ultrasound, and this will give us some rough idea of how the woman is going to respond to the stimulation. So approximately how many follicles we can expect in response. We also test the baseline hormonal profile, and we shouldn't leave it out, the semen analysis of the partner. So what we consider to be the optimal ovarian response? The optimal response for the woman around the age of 35 is the gain of 10 to 15 oocytes, because it doesn't pose risk of the ovarian herpes stimulation, and there's a fair chance that we will get sufficient number of good quality embryos. Of course, there are different stimulation protocols that are designed according to different types of ovaries and different types of the hormonal results. So if we look at the technology, one of it's not in US, but it's quite widely used at the moment, is the genetic pre-implantation testing of the embryos called PGT-A. It's not suited for all the couples, but PGT-A is a good tool when the patient has, for example, a history of repeated miscarriage, repeated failed embryo transfers without having any other related infertility factors. And also in women between the ages, let's say 36, 38 to 40, when there is a fair chance and good ovarian reserve to have a good, decent number of blastocysts. So basically what PGT-A does is to identify the euploid, which means genetically correct embryo, that will come first for the embryo transfer. It will reduce the risk of miscarriage due to chromosomal abnormalities, and logically may shorten the time to successful pregnancy. It does not guarantee live birth of, let's say, completely healthy child, because there might be some abnormalities that are not genetically linked. And also the patient should keep in mind that she should go through a normal screening processes during pregnancy. And it doesn't guarantee 100% chance to get pregnant and a perfect embryo as well. So what we can focus on when it comes to laboratory environment. So for example, in male infertility, there are some advanced techniques in order to pre-select the best sperm for fertilization. We also use the time-lapse monitoring, which doesn't itself increase the quality of the embryos, but it gives us some more thorough idea how the embryos develop in the early development, and also provides the embryos with stable conditions. And there are some emerging AI methods to assess the embryonal development to help the embryologist to pick the best embryo without the invasive testing for transfer. Also, when we look at the adjuvant therapies, some of them might be suggested, especially in women with lower ovarian reserve, such as the androgens, that should boost the follicle recruitment and to increase the number of follicles available for stimulation. The same applies to the growth hormone. But for both those two treatments, there is some quite long period needed when the medication has to be applied before the IVF cycle, usually about three months. And also the patients should be focusing on having a healthy lifestyle, including the balanced diet, weight management, if the patients are overweight or underweight, for example. And we also check for any other abnormalities such as thyroid dysfunction, etc. So the key point is that we know that in women after the age of 35, the IVF is feasible. However, the chances are reduced due to high percentage of abnormal eggs resulting in abnormal embryos. So we need to individualize based on the findings from the hormonal profile, and we have to select the best embryos, which, for example, the genetic testing might help us with. Thank you.
Thank you so much. Thank you so much, Dr. Kristýna. And your voice lasted amazingly well. So thank you.
Thank you.
That was wonderful. And I think this is so important because, you know, and I'm sure you see this far more often than I do as a practitioner, but we are seeing, I think, increasingly women and couples who are over 35 presenting for treatment for a whole range of different reasons. And so this information becomes particularly important, I think, for them, because, of course, things, as you've already said, become much more difficult. I'm just going to come back to that slide afterwards and perhaps provide some information about contact. But it's such an incredibly important topic because purely because, I mean, I know in my own practice that what is happening is we've got people just taking longer to find their life partner or make those decisions about having a family, and therefore at this point it does become much more difficult. And it's really interesting you talking about the looking at the predictors like AMH and FSH LH testing and antral follicle count scanning, but also the use of PGT-A. And one of the questions I wanted to ask was, it was interesting that you mentioned the use of AI, and I wondered whether using AI to determine the use of which embryos to use, or whether there was a comparison between using that and PGT-A, or whether it was either or.
Well, there are some studies, but so far the AI is not working the way that we would imagine it to be eventually in the future, because we know that when the embryo develops, some factors may suggest that the embryo is not genetically fine, but still within the best quality blastocyst, you might have aneuploid embryo. So we still don't have the pattern that would identify which might be the leading genetic issues when it comes to the embryonal development. So in order to create a software for this, you basically need thousands of embryos that you would put through a time lapse, and then you would genetically test them, not only performing a single biopsy, but like doing multiple biopsies, which would basically mean that you would destroy the embryos. And you cannot just create an embryo for let's say the technology's sake. So we've been cooperating on this with some colleagues from the technical university, and usually it's the embryos that are doomed to be discarded for some reason that might be used, and a couple, of course, signs an agreement that they might be used for the scientific purposes, but it does take quite a long time to gather up the information, and so it does take time to develop such a thing.
Yes, yes, it's all. I mean, but AI particularly is still very much in its infancy. I think there's a way to go with that. Yeah. So the other question I wanted to ask was, um, that particularly with women in this age group who might have suboptimal egg quality, um, what is the role really of the sperm in that? So I guess what I'm saying is, if you have sperm that are really good quality, is that going to help to improve outcomes? Or if they're not so great, does that impact outcomes?
Well, again, we have the data for that. We know that because we are able to distinguish if there's a chromosomal issue in the embryo. We are able to distinguish whether it came from the egg or the sperm. And we know that 80% of the chromosomal abnormalities are derived from the egg originally. So the sperm itself doesn't have too much of an influence when it comes to genetic abnormalities. However, it does have the influence on how the egg will get fertilized and how it will be developing. Because what we know that there is some kind of a pattern here that if the embryo doesn't develop further than day 3, then it's most likely, it might be a combination as well, but in most of the cases, is the sperm to blame for this.
Okay,
Because there are different mechanisms and there are like different energy sources needed for the earlier embryonal development and then to create a blastocyst. So it does have an impact, not so strongly on the aneuploidies, but on the embryonal development itself.
Yeah, that's really interesting, because I think men do need to know that they are an important part of the process, and actually being in really good or as best quality health as they possibly can be will influence the quality of their sperm and then and help with outcomes. So I always feel a bit sad for them. I think actually making sure that men know that they are important and they are an important part of the process is important, and also in this scenario it is very important for them. So yeah, that is really interesting. Thank you for that. The other thing I thought was really interesting and also very important is that it needs to be an individualized approach. I found that really heartening, because I'm guessing every different combination that you see of patients means that they have to be addressed slightly differently. So that's important.
Definitely, yes.
Yeah. Okay, so I can see that we have got some questions in here. So I am going to go right back to the beginning. We've got quite a few. The shorter ones I won't display, but some of the bigger ones I will, because there's some quite lengthy questions sitting in there. So we have the first one is somebody who is asking that she has high egg reserve for her age, no sperm or hormone issues, unexplained infertility, and about to start IVF. What are the best tips going into egg retrieval cycle?
Well, this is a hard question to answer without knowing the background of the patient. So generally, if you have a good ovarian reserve, then usually at the first protocol, we opt for something that's called the short antagonist protocol, which usually allows us to gain good, decent number of DX throughout the stimulation without having the risk of overstimulation. But the doses that we pick depend on the weight, the results of the hormonal profile, the antral follicle count, etc., and the age as well. So yeah, this is really hard to say without having all those data available.
A little bit more information. And also, I'm guessing what we don't know is how many cycles she may have had and whether there's been any pre-screening and any preparation. So I hope some of that helps. So the next one, I think I probably can read this one. So this is someone who has endometriosis, adenomyosis, and PCOS, excellent maturation, good fertilization, but a poor blastocyst rate. Getting from day 2 to 5 is the problem. Is there anything someone 40 plus with high AMH and OHSS risk, ovarian hyperstimulation risk, can do to help get to blastocyst, and what transfer protocol is best, and what testing should be done?
Okay, this is again a very tricky question, and I don't know the history of the patients. I understand that she's been through multiple cycles. With the PCOS patients, we know that the egg quality is sometimes compromised because you do have more eggs. However, the egg quality is a bit lower. Plus, you have the age factor as well. So most likely, if this was my, let's say, native patients who had never had an IVF, I would go for quite, let's say, the minimal to low dose stimulation to start with. Even lasting for a longer period of time in order to get not too many eggs, to focus on the quality. Also focusing on the triggering method, like using a double trigger, for example, in order to get most out of the follicles. When it comes to the transfer itself, the patient mentions adenomyosis. Again, I don't know the extent of the disease. If the adenomyosis is advanced and is affecting the whole uterus, then we usually opt for some form of downregulation. So to freeze all the embryos, then prepare the uterus for implantation later.
Yeah. So I'm guessing, and this will apply because we've got some quite complex questions that have come in with, which I think are probably quite difficult for you to answer, but I'm guessing you're quite happy for questions to be forwarded on to you if they want to come speak to you at the clinic. So
yeah, definitely.
They can just get some more individualized information. So this is somebody who's 40. One previous egg collection and only one ovary was accessible. Are there any tips on how to possibly access both ovaries for next egg collection?
Well, that depends. Why is the other ovary not accessible? If it's some kind of adhesion process, then there's not much that we can do to mobilize the ovary in the pelvis. Sometimes with the stimulation during the egg retrieval, we are able to change the position of the patient a bit in order to move the ovary down where we need it to. But in some cases, we, for example, find that there are some fibroids that are actually blocking the way for the ovary. So again, hard to say if it's adhesions, and if we need to access the ovary, then the patient can be referred to, for example, laparoscopic revision of the small pelvis in order to set the anatomy to a normal standard. And sometimes we access the ovary not vaginally but transabdominally, but again, there has to be conditions for that.
Yes, yeah. That sounds that, so maybe it might be sensible for them to have a more detailed individual conversation with you. I think. I understand these are really quite complex questions. It's difficult to answer them, but they're really amazing answers. So thank you. So this next lady has had 2 miscarriages a year ago. She wants to try again with a new clinic. She's 59 and she wants to know what her chances are of getting pregnant with a clinic that I think she's using donor eggs, so she would like a little bit more information. And is that something that your clinic would offer for a 59-year-old?
No, it's way over the age limit. It's actually 49 and 49th birthday, so it's 48 plus, and the day before the birthday of when the woman turns 49. So we know that the uterus ages as well, so it's not such a strong impact as on the ovaries, but there is, of course, the aging does affect the vascular flow inside the uterus. So let's say anatomically wise, there might be this kind of issues with the placentation, and so of course the chances are a bit reduced compared to a woman who is, let's say, 42.
Yes, yes. So I think probably I'm just going to say I'm so sorry to hear that you've had miscarriages. They're so distressing. But I am sure that there are clinics who, maybe specialise in working with women of that age, because that is a very specialist area. And as you say, understanding the anatomy and the functionality of individual uterus will become really key to success and outcomes. So I'm going to wish you luck with that, and I'm sure there'll be some other information for you available. This one, let me just find the next question. Let's see if I can display it. It seems to be not displaying very well. It's quite a long question. There we go. I'm going to display this because it's quite long. I want to miss anything. So, can a frozen embryo that is observed by an embryology lab to be a 3pn and then once thawed and transferred be able to attach to the uterus lining and potentially self-correct, assuming that was an accurate observation during the gestational period? Also, could a 3pn evaluation of an embryo actually be a misleading reading by an embryology lab? I.e., could it have shown 2pn indication briefly, but the 2pn indication was not present and missed during once or twice a day observation? Again, this is a really complicated question. So I guess what she's asking here is about, this is Matt, so sorry, Matt. Basically is about observation. Are there fluctuations that could be missed? I'm guessing. I'm aware about the concerns about a molar pregnancy if an embryo that is deemed to be non-2pn embryo is transferred.
Okay, so let me just briefly the introduction to biology. The 2pn indicates to prenuclear that we are used to seeing around 17 hours post-fertilization as a sign of the correct fertilization. However, we know that there are some variants of this, even if the embryo has some other number of the prenuclear, such as 1, 3, or more, it still may be genetically correct. It depends on whether the embryo has been kept in the time-lapse monitoring, because with that you have a more detailed view of the embryonal development, and the lab can actually go back and make a revision and see whether this is a mistake or not. If the embryo is kept in the normal incubator, of course there might be some let's say misinterpretation, because the embryo is just taken out of the incubator, put under the microscope for a very short period of time, and then again it's put back. So depending on the method that the embryo was kept in the lab, but still normal euploid embryo might come out of it.
I'm going to suggest, Matt, that I think you've said, could you have an email reply? I'm going to suggest that you make direct contact with Dr. Kristýna, so there can be some more information about your individual circumstances, and a conversation with the clinic directly might be helpful for you.
Okay.
Yeah. I think that might be. I'm guessing maybe helpful. We've got quite a lot of questions in this morning. evening. I hope you're happy for me to keep going. Your voice
Yeah,
starts
so
out.
far, yes.
Just say. So, losing some of them, just bear with me. So, I'm 39 with a history of stage 4 endometriosis, low ovarian reserve, ligated tubes, and after 9 years of struggle, laparoscopies, 4 IVF cycles, I got 1 euploid and 1 low-level mosaic embryo. Unfortunately, I lost my only baby boy euploid due to premature cervix dilation in the second trimester. I did another retrieval after loss, but got all aneuploids. And she's just, I'm not really quite sure what you're asking there. I am guessing what you're asking is, what would be a way forward for you?
Well, there are lots of like missing information again. The stage 4 endometriosis, if it's active, then most likely I would send this kind of patient for a surgery to reduce the endometriosis prior to the implantation of the euploid embryo to maximize the chances. Then, if there was a preterm delivery, then definitely focusing on sufficient progesterone levels, like keeping the vaginal progesterone even after the first trimester as a prevention of the preterm delivery again.
Yeah. Okay.
So, and it also depends whether the patient has had any cervical surgeries.
Yes. Yeah.
So,
I think it just sounds as though you need a lot more information to give a comprehensive answer. So I've said, I've been saying this quite a bit this evening, but I do think perhaps, a more detailed conversation with you might be useful, so that you can provide a more comprehensive answer. We have got lots of really quite complex questions in this evening. So I'm going to say thank you for answering them as comprehensively as you can. This next one I'm also going to discuss because again, it's a long question with some quite a lot of information in, but I'm guessing there might be some other things that might be missing. So this looks like it's continued, but I can't. Please forgive me because I can't actually work out where it's continued from. So I think this may be. I'm just going to. I think the only thing I can do is actually read it through because I cannot work out where it has come from. And we've got so many questions that have come in. So I'm just going to read it through, I think. So this was someone with a long, previous protocol was long lutron suppression. And this cycle, they're suggesting luteal phase estrus antagonist protocol with double trigger or clomid flare-up protocol. And growth hormone during stimulation. I don't know which protocol is best for me. Please, can you help? I have 5 antral follicles in the right ovary and 2 in the left, as I have 1 endometrium and 2 in the left side, and the follicles are not visible. I'm taking all possible supplements that can help me for egg quality and quantity, trying improving diet and lifestyle. My last appointment gave me a 10 to 15% chance of having a baby at my age and with my history, and I'm very upset. What is your thought on my case? I'm so sorry. It's a really
this is really like difficult situation. And so I'm guessing that long protocol didn't work too well in this patient. So doing the estradiol estrase treatment should actually prevent a premature rise in the FSH and should optimize the growth of the follicles through stimulation. So I think it's a good choice. I personally don't have much experience with adding growth hormone just do the stimulation. All the data we have, it does need some time to see any effect. So I personally don't have any experience with that myself. We see that the follicle count is quite limited, so it's 5 plus 2, so 7, the maximum, plus the endometrioma. Again, we don't know whether the endometrioma is in the way to collect the eggs or not, so it might be one of the limitations throughout the stimulation. Of course, I think you're doing your best. I mean, in terms of using all possible supplements and having a healthy lifestyle. However, the aging is something that we cannot improve with supplementation. You can only focus on, let's say, the quality of the eggs at a given moment. But if there's been any changes in the past, we cannot rewrite them.
Yeah,
unfortunately.
Yes, and thank you, because I think, one of the most important things in all of these circumstances, I always say, is being kindly honest, so that people really understand. It's really important to understand that the realities of what can be achieved for them, and I think that's incredibly important, because it allows people to make informed choices and decisions. And what I'm going to say, is we wish you all the luck, but it sounds as though you really are doing everything you possibly can to improve things. So, how is your voice bearing up?
Still a bit, but so far I'm still speaking. Yeah.
We won't do too many more. I don't think. Anna's just said, will this session be available to view later to catch up? Absolutely, I can answer that one. That'll save a bit of voice. Yes, definitely, you'll be able to watch on catch up. So yeah, we will be there for you. We have these ones seem to be quite simple, actually. Does age affect the sperm? If my husband is 58 years old, do we need any tests before creating the embryo?
It actually does. We usually see a change of pathology, right? Like having a lower quality of the DNA of the sperm with the male aging. It doesn't have, as I mentioned before, such a strong impact on, let's say, the genetic quality when speaking of aneuploidies. We know that male age factor might be related to some bit higher risk ratio of some very rare brain tumors or leukemia, but there's a correlation in between those. However, there's no way how to find out in advance. What you can actually do, if the parameters of the sperm are within the norm, you don't need to test anything extra. If, for example, the pathology is a bit higher, or if there's some issue, what may be handy is to do the DNA fragmentation test.
Excellent advice. Absolutely. I hope that answers your question, and just yes, understanding that sperm are important too. So wonderful. Thank you. And I think this is probably the last question, and then we can rest your voice. Do you use long protocol at your centre at the age of 36 in patients with endoadenomyosis? 8 failed embryo transfers, 10 embryos, only 1 was genetically tested, 2 of them early MA in 5 to 6 weeks, the last 3 transfers after 2 to 3 months of downregulation. Any advice? Thank you. 3 IVFs with short protocol before.
Yes, we would definitely use long protocol in patients that have sufficient ovarian reserve, because despite the fact that long protocol is suggested even in the low responders, we know that when we downregulate the ovaries, then it might be, with women with diminishing ovarian reserve, it might be too hard and almost impossible to get any response. So if the ovarian capacity is fine, then a long protocol might be an option. However, what I would suggest to consider the PGT-A testing, since you had 2 miscarriages. The question is whether the miscarriages were due to genetic issues or the adenomyosis that, of course, might play a role. And also the question is whether the regulation was done only with the injections, or it seems to be beneficial for women with adenomyosis to add letrozole to the downregulation as well, because it does affect the adenomyotic tissue itself.
Okay, that's really helpful. I'm sure that will be very informative, but difficult because again we've had some really complicated questions this evening with great chunks of information missing. But I think we've answered everybody so far. So what I'm going to say is a huge thank you, and a thank you for staying with us, given that your poor voice has been challenged. So I think what we'll do is we'll stop, and if there are people who've got other questions, then they can send them in, and at least then you can answer them via email and save your voice. But I just would like to say on behalf of my IVF Answers and the European Fertility Society, huge thank you for being with us this evening and for carrying on with a very croaky throat. And I hope that recovers very quickly. And also a huge thank you to everyone who sent questions in. They were actually probably, of all the sessions I've done so far, these have been some of the most complex that have been sent in. And I think that probably tells us an awful lot about patients trying to conceive when they're over 35. So obviously it becomes much more complicated. So yes, I'm just going to say a very big thank you, and anyone who is kind of with us can watch this on replay as well. Go and rest your voice and get better.
Thanks a lot. Have a nice evening.
And you have a lovely evening. Take care.
Bye-bye.
Thank you everyone for joining us. Bye-bye now. Bye.